Good afternoon, everybody. Welcome to this last session of the day. I realize it's been a long day with all the online sessions, but I think we have a very interesting last session about knowledge translation from theory to practice. My name is Henk Hilderink. I work at the National Institute for Public Health in the Environment in the Netherlands. And I'm currently also president of the Foresight section. And I'm doing this with Elena Palari. Maybe Elena, you could quickly introduce yourself.
Okay, thanks, Hank. Hi, everyone. For those who don't know me, I'm also co-leading the Knowledge Translation Working Group with Hank for the Burden of Disease Cost Action Network. I'm a researcher at University College London and also affiliate researcher at King's College, and my work is mostly around research impact assessment and methodology for clinical trials. Yes, Hengo, back to you.
Okay, thank you. Yes, as Elena already mentioned, this presentation is part of the European Burden of Disease Network. So the word burden of disease already has been mentioned up to now. And Elena and I are leading actually the work package on knowledge translation, but Elena will tell you more about that later. It's good to realize that European Burden of Disease Network, these are the nice pictures, especially at a conference, online conference like this, when in the old days when you could still meet physically. Hopefully that will be next year in Berlin also the case, but we are a very lively, active Burden of Disease network with a lot of exchange of experience, of methodologies, and also training schools to do a capacity building as well. So actually, before we want to start, we want to as well, the outline for today is going to be, we have an opening and we have two questions with a Mentimeter. I will show you later. Then Elena is going to tell you a bit more about the background, the theoretical part of knowledge translation, especially in relation to burden of disease. Then we're going to have a presentation from Dr. Aline Anton from the Robert Koch Institute about Burden 2020. That's really, I think, a very new study that's being published. I just heard that yesterday the English version was online. Then we're going to have from Dr. Ian Grant from Scotland, the Scottish Burden of Disease study. And at the end, I will present the Dutch National Burden of Disease study. And hopefully we have some time at the end also to address some questions. But first, we're going to go to the Mentimeter. And if you can go there. Oh, I cannot. You can just use your mobile actually to scan the QR code, and you will go directly into the Mentimeter questions. So actually, the first question is: what is the most difficult aspect of knowledge translation regarding burden of disease? And I have to say, there's not a good or a bad answer. This is just your idea about how you regard knowledge translation in relation to burden of disease. You can also just type menti.com and then use the code that I'm saying that is displayed here. I can see 9 people, 10 people just filled in already the questionnaire. Just scan the QR code and then you will go directly to the page. We will wait till we have around 15 to 20 answers. I can show you the results in the meantime. It's a little bit of a fuss with all the different screens that I have, but I think here you can see. I was hoping to get it in full screen. So actually, what we can see is that, let's say, interacting with policymakers and stakeholder engagement are considered to be very difficult aspects, but also access to sufficient resources. Yeah, that's something that we can never help you with, to also give you financial resources. But we can help you within the cost action burden of disease network with finding the right expertise or helping you with doing the burden of disease calculations. So, but it is about interacting with policymakers, of course, and stakeholder engagement in practice, what is very often considered to be a difficult point. Oh, now I'm trying to get to the next question, actually. Oh yeah, and the next question is, what is needed actually to make the gap between policymakers and BOD researchers smaller? And I cannot see the results. Oh yeah, there. It won't go to the next screen. There we are. That's always interesting to see that. I assume that many of you are researchers. I saw some Mentimeter questions before. The profile of participants to the European Public Health Conference is very much a research background. And of course, we have to do a lot of effort as well to reach out to policymakers. But also policymakers should also, 30% thinks that that it also should be from policymakers. More attention to policy interventions, that's also an interesting one. And more detailed data and results, that it's not going to help to close the gap. I think we're going now back to the presentation. And sorry, and we're going to go to the first presentation from Dr. Elena Pallari. Elena, the floor is yours.
Great, thank you very much, Hank. So I'm sharing now my presentation. I hope you can see it. Can you see this, please?
Yes, we can see it, Elena.
Yeah, excellent. Yeah. All right, great. So today, following on from what you were saying, Hank, about research and people who are in this conference today, but also in our session, we're trying to engage with practitioners and policymakers, so outside the research arena, in order to promote the concept of burden of disease for use into practice. And this is where we come in, and what we have been doing as a network. And I would say feel free to go to the website. You can scan the QR code here and get in touch with us in order to work together towards this collaborative effort. So today what I will be doing is give you an overview of what I've been doing with regards to the working group on knowledge translation, what are some of the results today, the progress that we've made, along with the next steps. So the first thing, assuming that you have some familiarity with knowledge translation, if not, there are different definitions out there. One that we're using is from the World Health Organization, which is defined as the synthesis, exchange, and application of knowledge, so that the various stakeholders who are involved can accelerate the benefits of such innovations in order to improve people's health and strengthen health systems capacity. And there are different frameworks out there as well. For example, from the Canadian Institute of Health Research, from the WHO, from the Cochrane collaboration, which I'm going to show in the next few slides. But the point I'm trying to make is that even though there are different frameworks, what we're trying to create is to use that knowledge in order to work towards the use of evidence from burden of disease studies directly. And there have been different models out there as well. For example, on knowledge translation, push efforts, where these have been mainly from the researchers, so people who are working in research and using that evidence. And also pull efforts, where the research users are driving the need for the creation of such knowledge translation frameworks and use of that evidence. What we're trying to do is move from A and B model to C and D, where we work collaboratively, exchange with the different stakeholders and relevant working groups in order to enhance the promotion of different evidence from the field of burden of disease specifically into practice and health policy making, for example, in setting priorities. In this work, the Cochrane's framework has been also very useful, where we set priorities and co-produce this, as well as the different models that I have just mentioned. But overall, it's also about improving the climate and building an infrastructure that is effective and sustainable. So we don't want this to be neither a one model fits all approach, but rather something that we work collaboratively together and that is sustainable, so that different countries can use this, for example, for their benefit. And in our case, we worked on a working model of knowledge translation, where we have scoping, doing, producing, and monitoring. So here we're working with the use of different data sources, as well as different stakeholders, in order to produce the appropriate evidence and setting the appropriate priorities in a country, and hopefully moving on to the sustainability stage, where we monitor and create a sustainable infrastructure. So, so far within the working group, we tried to move from the theory of knowledge translation to burden of disease in practice. And for this purpose, we set a 5-step process, from creating an inventory of good practices to using, for example, DALIs and disseminating their use, as well as working on a diagram, for example, when it comes to policy making communication, or other sort of infographics or simple guidance that people can use in order to create their message. And then moving on to the impact on infographics, so that we create simple forms of layouts where people can use this data into practice. And finally, something that we haven't worked on before, but we need to consider, is how, for example, when we talk about the burden of disease data and sources and the different stakeholders, is also to evaluate the impact of that work, and not only, those numbers or those estimates that are being published. So, so far we had 3 aspects that I will be talking about. Firstly, we had a virtual working group meeting last year in December. We disseminated a series of questions before the meeting, but also during, where participants indicated that they consider, for example, calculating COVID-19 burden of disease studies, also its indirect effects, which I think this is quite important, because 2/3 of the people, demonstrate this interest. But I think what is more important when it comes to knowledge translation is that about 84% indicated that they consider quite or very important to develop a knowledge translation toolkit. And to this aspect, we have touched upon the different challenges, such as accessing resources, and this is something that has come up also during the subsequent sessions. We held 2 training schools, and as you can see, we score quite high in terms of the satisfaction with the course. This was a very basic introduction to knowledge translation in terms of the content, the organization, and the instructors. And what we're hoping is to develop an advanced course on this. Also, we set a series of virtual sessions, where the idea behind this is to be able to establish who has a mandate, or, for example, burden of disease, see the different organizations within each country, and create links and networks of organizations and individuals with an interest in order to promote the uptake of data use on burden of disease. Secondly, think of simplified ways so that we explain the concepts of burden of disease, but more importantly, explain the value of burden of disease and how it can be used on setting priorities, on setting research agendas, or on defining, funding and other important challenges that need to be overcome. And finally, we have touched upon how we can link this with regional, national, and hopefully global burden of disease initiatives, so that we bring this in a harmonized way through this technical platform. The next steps are to move to an advanced training school, and where we are hoping to reintroduce the working model that I've shown you earlier. The participants will have the opportunity to work on their own knowledge translation projects. They can choose the country they want, the disease area, and then they can work on the identification of sources for their country, the gatekeepers, stakeholders who are involved, and how they can go about the different steps and stages of translating the project. Yeah, if you have any questions, you have our details here, and also on the very first slide, and probably you have the QR code. And also if Henk would like to add anything further to this. Thank you for listening.
Nothing to add, Elena. Thank you very much for this nice overview. Good presentation. I think this is important work. I'm having a look at the Q&A, and I don't see any questions there. If you have any questions, please put them in the Q&A section. I do have a question to Elena, actually, because from the Mentimeter, stakeholder engagement was seen as one of the difficulties. Is that also something that you address in the working group on knowledge translation?
Yes, absolutely, Henk. Thanks for that. So stakeholder engagement is one of the top challenges, and something that we have found, for example, in smaller European countries, that is a great barrier. Even if you would be thinking that, you know, smaller countries might be easier to find the appropriate points of contact, but it might also mean that there is a fragmented system in place. So you need to identify the relevant stakeholders and people to engage with. So this is one of the challenges that we're hoping to address through this working group. And already we have suggestions from several members and transferable lessons from their countries on how we can go about it.
Okay, I can see some other questions in the chat, but maybe you could also directly address them, and then we proceed to the second presentation.
Yes, I can see they're asking who are the participants for the Advanced Knowledge Translation course, and how would they please recruit it? Yes, so the idea is that we have an open call, I believe. So if you check on our website and keep an eye on that when the announcement is made for the advanced training school, and you can apply directly. There will be funded places as well through the network, and we're hoping to recruit participants who have a great interest on using burden of disease studies. And as I said, the idea is to use real hands-on projects and work on knowledge translation projects for their disease areas and countries of interest.
Okay, thank you. Then that's a nice bridge, because I think one of the good examples now is the the German burden of disease study, Burden 2020. And we're going to have a presentation from Dr. Aline Anton from the Robert Koch Institute. We have some technical problems, so I'm going to share the presentation, and then we hope that everything is going to work out.
Great. Yes.
Aline, the floor is yours. I will see.
Thank you very much, Henk.
Put your presentation up. I think you can see it now. Oh, sorry. There it is.
Perfect, thank you. And then we can directly start. I can hear myself. Not sure how to deal with that, but
I think if Henk can mute yourself during the presentations.
Let me try to do that. Sorry, then I have to go back. Now my button is...
Perfect. Then we can directly go to the next slide. Okay, so I will talk about the Project Burden 2020 and all the decisions we made regarding publishing and disseminating results and providing all necessary information. This is not so much about reaching out to policymakers, but this is because this is our next step then. And Burden 2020 is a German national burden of disease study that started in 2018. And after almost 4 years, we are now at the point where all indicators have been calculated. And on mortality, the YLL, we have an all-cause mortality, and for morbidity, YLD and DALI, and also risk factors, we have made a selection. And the aim of the study was to provide information on the regional level and have, in the end, a freely accessible information basis for policymaking and healthcare planning. Next slide, please. So there have been a couple of basic decisions that we had to make regarding scientific publications. Next. Information about the project and all methodological decisions, how to present our results, our indicators in a results tool, how to integrate satellite projects, what about the general dissemination, and then as a next step also the knowledge transfer. And that all was combined into the idea that we need a website, so we kind of recommend to present things like that on an own website, or if possible to integrate it into an existing website. That was not possible for us, especially with the results tool, but might be in the future. Next slide, please. So a couple of these things I mentioned, and next click. We have already been integrated into our website. The website is called dali.rki.de and is now available in German and English as well. And there you can find all basic information. And I will talk now about the different aspects that we integrated. Next slide, please. When it comes to scientific publications, that's a basic thing to do about projects like this. We made the decision that we wanted a journal that is freely accessible, to that our main publications should be available in a widely known journal, that it is bilingual, that we can present our results in German and in English as well. And we also decided for a medical journal and to present the results in 3 parts, 3 main parts, not all in one, so that we can kind of publish it step by step and create maybe more interest by that, not waiting all 4 years till we have something available. And already published is the Years of Life Lost, the YLL results, and under construction right now, and hopefully will be finished by end of the year as well, YLD and DALI, and then we will present risk factors as well. Next slide, please. And this is just a small thing. It is quite useful to use current events. So hopefully there's not a pandemic every year, but during the pandemic, basically we wanted in our selection of diseases, we only had one communicable disease. But then we had the data for COVID available at the RKI, and we decided to use them to demonstrate that we can apply the burden of disease methodology, and that this can add value in pandemic surveillance. And we published these results and announced them via press release. And it turned out that it was picked up by more than 50 media, including very well-known nationwide newspapers and online magazines. And that is quite rare to happen for a small research project. And the decisions about providing general information and to create transparency also were that we will publish everything on our website. You see here screenshots of our website, and Next to presenting all publications and of course link them, you will find all data sources for our indicators that we used. For example, right now you will find the data sources for mortality, and when we publish the YLD, there will be also the data sources for morbidity. And we will add all final reports and also the technical protocol. So for everybody who wants to dive deeper into the methodology, you will find everything that is at least in theory possible to know everything, how we calculated these indicators. And if you have a look at the lower right corner of our website, you will see versions. And next slide, please. So for all data available, we decided that we have a kind of logbook, and every time we update data or add data, you will be able, or people who download data will be able to have to cite them and know which version they have. And yeah, you will find what we added. Right now we have our first version of YLL, and within the next couple of days we will extend that to all courses and all regions, and then after that we will add YLD. So with the results tool, that's also on the website. That's the main part of the website. If you can show the film, I will explain what you can see when having a look at the results. You will easily find them. There's two ways to go to the results, and then you have an overview, what you can choose, which kind of visualization. For example, here you can see the map, and you can choose a region. We have the states and the spatial planning regions. You can choose the regions, you have the numbers, and you can compare these regions. We also choose a classic burden of disease tree map, and you can choose the level of disease. And when it comes to gender, you can see both or male, female, and explore the diseases. And then we have the age progression diagram with also levels, and you can compare up to 3 diseases and also compare the gender. Thank you. Next slide. And also within the results tool, next we will add is another kind of visualization that might be quite appealing, where we want to combine burden of disease indicators with other indicators. For example, the first that we did is to combine YLL and the social deprivation index that was available for us. And what you can see here on the map is that you can choose a region, and you see YLL per 100,000 inhabitants. And then you also see the level of the social deprivation index. For example, dark blue regions are the ones with the highest number of YLL and the highest level of social deprivation. Next slide, please. When it comes to more dissemination of the project, just to make it more well known, we used a couple of platforms. You can see an example from the cost spotlight that was that's kind of very appealing. We published that we made a survey about headache prevalence and severity in Germany. Next to that, you can just an example, you can use every platform that might be suitable to your project. Members of our team have been invited to podcasts. There are a lot of scientific podcasts out there. And next to, of course, conferences and workshop also with stakeholders, we will provide access to data journalists as soon as the data are ready before they are published, and to have them explored and published to a wider audience. And we also choose to produce professional graphics that we can use for publications, presentations, and also our website. And next slide, please. And we also produced a short explanation movie. Maybe you can play it, Hank. Not sure if you can hear the sound. No, sound is not. you can see these movies. It is a 2.5-minute movie that explains the burden of disease and how to use it, why it's useful for stakeholders. And we also decided to cut it into smaller pieces so that we can easily use these small snippets for presentations or for social media and to spread them more easily. They're available on our website as well and at the YouTube channel of RKI. And as a last slide, with knowledge transfer or knowledge translation, it was extremely helpful for the project to be part of a mostly international network from the beginning, from the start. And now the COST network is a main network. And I also mentioned satellite projects. So out of our projects, Project Burden 2020, we have 2 more right now. It's a Burden of COVID-19 project and the Katinka project. The Katinka project is about capacity building and bridging countries from Central Asia and Southern Caucasus to the COST network, for example. So it's extremely helpful to share knowledge and to spread all that we've learned, and also that other countries helped us a lot. Thank you very much.
Amazing. Thank you very much, Dr. Aline and Ton. Hank, would you like me to ask the questions in the chat, or would you like to?
Yes, I think we have time just for one question.
Okay, so there are several here for you, Aline, but maybe if I can ask one. Do you provide estimates at the regional level or estimates from the districts, cities of Germany below the federal state level?
Below the federal state level, we will present the 96 regional spatial planning regions.
Great, excellent. And I think this is a very quick question. Somebody says, congratulations to the team for this success. And the question is about risk factors. Which risk factors did you select and the rationale, if possible?
The rationale is what is available and what we have been able to calculate, because it was not easy to apply the GBD methodology to our data. That was quite complicated. The environmental agency that is our partner in the project has been quite good because they have excellent data, for example, for particulate matter. And we have 3 of these risk factors, and we wanted to do more, but we started with smoking and alcohol consumption with RKI data.
Okay, great. I think that's it. The layman's summary. The other question, I think you very well explained. There are videos, so maybe we can have those links. That would be great, so people can see them.
I can add them to the chat and try to answer questions.
Oh yeah, that's also, if there are specific questions that can be answered in the chat, please do, because people might bring in other questions as well. So if you this is for the presenters, if they can answer the questions in the chat directly, and then we can proceed to the next speaker is Dr. Ian Grant from Scotland, and the Scottish are doing a burden of disease studies already for quite some time. So it's very interesting. It's going to be very interesting to see how the current status is. Although we have, Ian has had some difficulties with the connection, so I think it's going to be a pre-recorded video. Then I will ask the Madalena from the technical support to. There's Ian as well.
Good afternoon. My name is Ian Grant. I'm a principal researcher at Public Health Scotland, and I've worked on a Scottish burden of disease study since it started nearly a decade ago. This afternoon, I will outline how we have used existing knowledge transfer tools to promote our work over the course of our study. Burden of disease studies face the same issues other health information producers do, in that simply having the data available or published does not necessarily lead to its increased use in policy and planning. The World Health Organization outlined some knowledge transfer mechanisms To facilitate these efforts, my slides today will highlight how our Scottish studies use these push, pull and linkage mechanisms to promote the use of our burden of disease data. Before I look at some examples of our knowledge transfer work, some background to our study and organisation. The Scottish Burden of Disease study started in 2012. Our aim was to monitor the population level contribution of our health conditions, diseases, injuries, infections and risk factors compromise our ability to live longer lives and better health. We are based in Public Health Scotland, the national public health intelligence organisation in our country. Its values and objectives, such as supporting national and local policymakers and planners, being data and intelligence driven and evidence informed, align very well with the aims of our burden of disease work. Furthermore, our organisation's reach is inclusive, looking to collaborate and build networks with and across a range of organisations and sectors. In theory, this places us as a burden of disease team in an advantageous position, but in reality, we're competing with other projects and studies across our organisation. So even internally, we need to be clever in how we promote and push our work, so our funding depends on it in the long term. So looking at some of our examples of knowledge transfer work, we've used a range of push tools, that is knowledge in accessible formats, over the course of our study. An early and obvious one is developing a website. You don't need results analysis to do this. Even without these, it can simply act as a signpost for the work and an early opportunity to promote and engage with potential users. Our web pages have evolved over time and in response to user feedback. And for example, we're currently developing a section based on that user feedback on providing practical examples on why and how users can use results from a burden of disease area in their local or national context. For our first set of results, we followed the traditional format by producing a series of reports covering both the overall burden of disease in Scotland, how it breaks down by age, sex, gender, etc. We looked at health inequalities as well, how that varies across Scotland. And we also produced a series of technical briefings detailing our methods and results for our 25 leading diseases in Scotland in terms of the disease burden. These took a lot of work and were very resource and time intensive, but we were very proud of these at the end of it. However, to our despair, at the time, what really got our study results noticed was this bubble chart infographic showing the scope of the diseases covered in our study and their contribution to the disease burden in Scotland. So whilst our reports gathered dust, this infographic was widely used internally and externally, and was a great initial signpost for others to access our work at the time. Our immediate learning from this was about the power of infographics in promoting our study and getting people interested in knowing more. So we started to tailor our push efforts in this direction, developing a number of infographics aligned with national and local public health strategies. So in these infographics, we're focusing on the discrepancies in the health burden between our poorest and wealthiest areas. These again landed very well with our external audience, and some of these infographics were used in separate publications from ours, just underlining the value of developing key infographics and key messages in alignment with national and local strategies. Turning to our pool efforts, to enable policymakers and planners to use our data, we've recently improved our pool efforts to house our estimates with an interactive R-Shiny dashboards, which contain user-friendly maps, such as this, where users can hover over the map and access the burden of disease results for their area. We also provide user-friendly charts, heat maps, and all our data is downloadable. This allows local policymakers to see the burden of disease in their area and how it compares with other areas nearby and with Scotland overall. But we're also conscious, though, that we need to promote linkage and exchange with our data users. And more recently, we've been focusing on building relationships between our study and our potential data users to share ownership and direction and to form some direction of our data products by using our organisation's internal and external networks. So, for example, Public Health Scotland have set up local intelligence support teams generally to support the work of our local community health and social care partnerships. So we're tapping into this internal network, this local intelligence support network, to encourage the use of BOD data information at a local level to inform needs assessment, health planning, and workforce decisions. We have also targeted the third or voluntary sector, as they are an active and vocal lobby in Scotland. We held a seminar involving representatives from 20 voluntary organisations of Scotland to get feedback on our results, our methods, and how best is to disseminate these results to organisations such as the voluntary sector. We've also developed blogs, trying to break down the language that's used in BOD into layman's terms and to make it understandable. And we've done targeted work with some national charities in Scotland, such as Versus Arthritis, a musculoskeletal charity, and the cerebral palsy charity BOBAF. At national level, we've had some notable success in getting our burden of disease data used. And our results and infographics have been included in a number of national reports, such as our Chief Medical Officer's annual report on the state of health in Scotland, disease-specific national strategies, such as mental health and neurological disorders. Our data has been used to support the work of the Drugs Death Task Force in Scotland, and we even had a motion in the Scottish Parliament in response to our findings. At a local level, we have started to gain some traction and have been involved in some pilot work with a number of local partnerships, with our data being used in a number of local strategic needs assessments and workforce planning strategies. And to end, I'd just like to end with some reflections on knowledge transfer in burden of disease studies from our team. I think you need to be clear at the outset what your aims and objectives are of your burden of disease study, and even aligning them with maybe the values and the missions of the organisation you're working in. Equally, at the outset, you need to identify the key stakeholders and involve them from the beginning. It's going to be done through a steering or advisory group or some other regular meeting setup. I think in Scotland, we've been lucky in a sense because we're a small country. Our networks are easier to access, the people are easier to access, and I think country size and the location of the burden of disease study are important factors in facilitating effective knowledge transfer approaches. It's also worth remembering it takes time to embed burden of disease into policy and planning thinking. It's a drip effect. We've been at this for a decade, and possibly it's only over the last 2-3 years that we've started to see our results appear in national and in local thinking and strategic documents. It's also very important that you make sure you have someone in your team that is good at data visualization, visualizing the data. And if you have access to a comms or press team, we'd recommend using them considerably. They are brilliant at breaking down the data into layman's language and even the data into nice, snappy infographics. And I suppose connected to that is try to stay clear of burden of disease technical terminology when pushing your results or disseminating your results. We think terms such as YOL, YOD, DALI, they're not intuitive to our potential data users, and actually in some ways possibly act as a barrier. So for example, when promoting our work more recently, we tended to replace these terms with new terms. So for example, YLD with ill health, YLL with early death, and DALI with health loss. I think that helps a little bit. It makes it more recognizable to our potential users. Once they get into a burden disease study, they can then start to understand the technical terms or possibly relate to them. And finally, join the European Burden of Disease Network. Great source of inspiration, lots of great ideas going across individual national burden of disease studies, and it has a stream of work dedicated to facilitating effective knowledge transfer across burden of disease studies. Thank you for your time.
Thank you, Ian. I don't know if you have the possibility of go online that we see you really live. But given the time, I would suggest we proceed to the last presentation. That will be me. I will be giving you some experience from the Dutch situation. I don't think Ian can come online. I think his connection is not good enough. So let me try to share my screen again.
Ian came back saying that he's alive and online. Good to have you, Ian. If there are any questions, feel free to put them on the Q&A. Yeah, and now we're very happy to hear from Henk about the Dutch example of the National Burden of Disease Study. Henk?
Yes, thank you, Elena. I think we can go a bit quicker, that we might have some time at the end for some questions. So this is the Dutch DALI's, the Dutch National Burden of Disease Study. And I'm presenting on behalf of Marianne Plasmans, René Poos, and Petra Eysink, my colleagues who are very active as well on the Dutch Burden of Disease Study. So actually, if we're looking at knowledge translation in relation to burden of disease, Elena presented already that you have different phases of doing a study: scoping, doing, producing, and monitoring. And actually, all of these phases have different aspects of the models that also Ian was mentioning, the push models and the pull models. Especially at the beginning, the selection of diseases and risk factors, then you have to get a lot of external knowledge from people. Data availability plays a role, but also from policymakers, what do they find interesting? Then doing the study, that involves a lot of methodological choices and data sources. And a network like the European Burden of Disease Network is then very helpful also to know what others are doing and why they are doing it. And of course, if we are producing, then we are thinking of all kinds of dashboards, infographics, reports, scientific papers, and then we're focusing much more on the push model of knowledge translation. And the last point, also rather important, often forgotten or a bit neglected, the evaluation of the results. How are the results being used? What are the users actually? And you can, of course, stimulate that by giving presentations that gives you insight into what people are thinking of your burden of disease study. Just to go back to the National Burden of Disease Study that we do at RIVM. I don't know what happened there. You are still here, I hope, and I see my presentation. I hope you still can hear me.
Yes, all good, Henk.
Okay. The National Burden of Disease Study at RIVM, we're doing that since 1997, actually, when we had our own disability weight study, and we used that to do our first calculations. And at the beginning, the selection of diseases was rather limited, 50, 60 diseases, no risk factors. But recently we moved up to more than 100 diseases at different levels. Also, what was mentioned by Aline, what the Burden 2020 study is doing. Unfortunately, we have a rich data landscape to do that. Mortality, morbidity, and risk factors are, we can have sometimes even more than one source for that is available. And over these years, we have applied a lot of methodological improvements, and I would call that the learning by doing, and we're still learning. So improvements are always going to be there. Something that we are focusing much more on is also the link to risk factors, applying the population attributable fraction approach. But the main question is, and especially for RIVM, that's important, how to provide valuable input for policymakers, because that's also something that we really want to do with the burden of disease study. So actually, the first question is then, when do you want to also to bring your results into the policy cycle? And here you see the, let's say, the classical representation of the health policy cycle. And of course, if you have the burden of disease, with all the ranking of diseases, you have maybe a priority setting for which are the most important diseases with the highest burden. But also the link to risk factors, then of course, that is linking to what policymakers can do and the strategies that they might want to implement to change something. So these are the two moments actually that you might want to involve into the health policy cycle. But of course, it's also important, and this is similar to what Ian was showing for Scotland. We did this also some years ago to show a little bit more about the ranking, having a very visualized way of showing what are the most important diseases at the different levels. We do also do that in time. We produce as well the Dutch Public Health Foresight Study, and then we can also see in time what's going to happen. And for example, dementia is going to was just in the top 10 in 2015, and it's going to be a #1 in 2040. However, I just took dementia as an example. We do have all kind of prevalence estimates available, ranging from 150 to 300,000 cases per year. And that, of course, depends on how things are defined, how many of the mild cases do you include. So this includes a lot of uncertainty as well, also regarding the disability weights. And the same is the case for the case of death, actually. If you look at the range there, it's also more or less ranging from 8,000 to 16,000 deaths. So, and that also has to do, of course, that many older people that die of dementia might have multiple health problems, and it might as well be some other cause of death that is playing a role. The main point there is there's no truth, actually. And what we invest a lot on is to create a support base with stakeholders. So that requires trust. You have to some kind of mutual understanding. And of course, we strive for, let's say, the one figure that we might present at the end, but it's also accounting for that people have different ideas about what the prevalence is. And that's not only the case for dementia, but also for many other diseases. But of course, one of the main the questions then arising, which of the disease burden could be avoided actually by policies. And then, of course, then you can go to disease burden by determinants, the underlying risk factors. This is something that we did in 2014. And you can see that smoking in such an infographic is being presented as one of the most important ones, but also interesting to see then we were not able to put diet things together, and you see that they are rather small, actually. Also, something interesting, we always add percentages cannot be added. In practice, many users just do it because they think it might be just approximate for the disease burden. Something that we did later in 2018, we had a new version of the infographic showing, first of all, different levels of the determinants by behavior, metabolic, occupational, and environmental risks. But also you can see smoking reduced from 13 to 9.4%, not because of smoking improvements or effective policies, but just because we improved the methodology to have the estimates for the total burden of disease. And here you can also see that unhealthy diet, if you put them all together, is all of a sudden number second in row after smoking. However, we got another question, but which policies are then best to target these determinants? And then it's becoming very complicated because then you're talking about effectiveness, because what is best? Is it about costs? What kind of target groups? You have all kind of lag times. So this is something that we want to invest on to serve better the policymakers' interest as well. So what are these lessons learned? That was what Ian also was saying before. The interpretation of BOD results is still rather difficult. It has a difficult unit, years lost, which amounts to many millions of years, and that it is rather difficult to interpret. However, we have to admit as well that results are not yet usable for policy processes. And that was also coming from the Mentimeter, that researchers have to invest as well to have to interact in a better way than policymakers. But to link to the risk factors is rather essential. That is something that we can see that that's the results that policymakers use quite a lot. However, then you also have to deal with all kind of, let's say, methodological updates that you are presenting. It helps what Aline was showing, that you can still go to the last version. However, yeah, it is still difficult to explain. The next step, of course, is to link it to interventions. And something that I would like to stress again, building capacity and mutual trust is rather crucial in the whole process of doing burden of disease. And that requires knowledge translation at all levels and all models, actually. And it's also good to understand, yeah, it's not the truth that we're doing, of that we're presenting. It's only the estimates of the burden of disease. And something as well, the use and the misuse of results, it's all in the game. And yeah, sometimes it's also being used in a very nice way, something that we saw that the Dutch government was then basing a health mission on actually the results that we had presented. So this is also something, some of a good example of a good use of the results of a burden of disease study. Thank you. And maybe back to you, Elena.
Yes, that was great, Henk. Thank you very much for that. And actually, we do have also a question for you. Somebody's asking if you can give the URL for some of these great burden of disease infographics. So maybe if you have the links, you can add them here. And also, I think you presented some work from a paper that you did on this. So I think that would also be great to be added here.
Yes, I will share the link in the chat.
Excellent. I don't know if there is anything else from either participants or the presenters. Well, thank you, Brecht. Brecht saying, and common excellent presentations and impressive progress and achievements. So indeed, thank you very much. I would say to Aline, it was really great to see what is happening in Germany and the amazing work that you've done, and the infographics and the work also is very impressive, and the data visualizations as well. And also Ian gave a really great example of how to do knowledge translation in practice. So I really look forward into taking this on board for our working group, Henk. So back to you if you want to add and
yes,
conclude.
I think you summarized it perfectly, and I would thank all the speakers again. I think this is showing as well that there's a lot going on regarding knowledge translation and burden of disease, but particularly the combination of them. And it makes it also rather practical, because knowledge translation very often can be a bit abstract thinking about it, but also applying it to burden of disease makes it very, I think, very practical, and also inspiring to see what is happening actually. So thank you very much for that. And I hope you have also an inspiring evening tonight. I think there's going to be some social events. I'm going to go for dinner. Unfortunately, not with you, but so we'll do that next year in Berlin then. Okay, thank you all for this nice session. And thank you, Elena, for co-hosting.
Yes, thank you, Henk. Thank you, Aline, and thank you, Ian.
Thank you, Henk and Elena, and also others.